Well, yeah, in the online version.
Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record, and also please remember to fill out the program evaluations. And we're always appreciative of ideas that you might have in regards to future topics and future speakers. Today I have the pleasure of actually introducing two intrepid co-presenters who have traveled over from Iowa City today. Amy Pearson attended medical school at the Medical College of Wisconsin before going to the Mayo Clinic, where she did her anesthesiology residency and subsequently a pain medicine fellowship, and she is associate anesthesiologist and pain physician at the University of Iowa now. Lee Kral received her Doctor of Pharmacy degree from the University of Iowa, and she is clinical pharmacy specialist at the University of Iowa Center for Pain Medicine, and they've kindly accepted our invitation to come over from Iowa City today to provide us with a practical opioid an update on practical opioid management in chronic pain. And please join me in welcoming Amy Pearson and Lee Kral.
Thanks. Thanks very much. We didn't die on the way here. I'm so excited. And I was the driver, which is even more exciting. Today we really want to give you some very practical applications and hopefully bring you up to speed with some of the talk that's going on, some of the rules that are being forced down our throats, so to speak, and maybe how to manage those in a very practical way in our daily practices. So that's really what we want to do today, and save enough time at the end for questions, because there's always lots of questions. We don't have anything to disclose. Always use your best medical judgment. Our objectives are to talk about appropriate steps for who should be started on opioid therapy and how we should do that. It's not as simple as writing a prescription anymore. Describing key points in the CDC opioid prescribing guidelines. We're going to go through a case that walks through each of the practical applications of the guidelines, and then identify approaches to de-escalating opioid therapy, which is what a lot of us are doing. Some of us have been doing it for 15 years or more. So what I want to start with is, how do we get here, right? We've all seen scary headlines and the news and things like that, and millions of people are dying. What I really wanted to give you is just a wee bit of the foundation. I've been practicing long enough that most of this has happened while I have been practicing pain management. I have seen this natural disaster happen, and even though I've tried very, very hard to prevent it from happening, it has happened anyway. I'm only one woman. So it all started way back in the ancient times of 1980. And I don't know if you've heard about Herschel Jick, but he was a guy out in New England who was one of the pioneers of data mining. And so he had this wonderful database at Boston, and he would do all kinds of data mining, and publish just real brief little letters and synopses and things like that, more epidemiologic than anything. Well, he happened to, as one of the things that he found, he happened to say, we recently examined, 40,000 hospitalized patients, and they were monitored, and there were, about 12,000 patients who had at least one narcotic preparation, only 4 cases of reasonably well-documented addiction. Wow. And unfortunately, this thing was published and promptly forgotten about. I promise. Nobody took this home and slept with it under their pillow. And then this happened, right? The Sackler family, who was running Purdue Pharma at the time, had a new product. They had MS Contin, but then they had a new product called OxyContin. And they needed to market that thing, and they were master marketers. They started direct-to-consumer advertising. They started giving more bonuses to prescribers and taking them on trips and lots of fun, good things, and all kinds of detailing, well without the prescribing indications for the medication. Because what was their goal? To make money. And so if you're interested, they're very good reads. Painkiller by Barry Meyer talks about the whole industry response and the whole healthcare system response to this. And Dreamland is by Sam Quinones, his family is originally from Iowa, Goose Lake, Gray Lake, I'm gonna get one of those wrong. It's around the Des Moines area, his grandmother, but he's a a Vice reporter in LA, and he happened to come across some information from West Virginia about black tar heroin. And then he started digging. And the things that he found out about in poor economically, suppressed areas like in Ohio, where they lost a lot of their manufacturing jobs, they were very prone to a lot of disability, a lot of unemployment, and they ended up sliding into opioid addiction, and therefore the Mexican drug cartel came in and said, hey, heroin is cheap. And they were master marketers. It was amazing, their marketing skills. They were right on. And they're very fascinating things, but it's all about the marketing, right? And if we weren't very, very critical and we weren't getting pressure from everybody, you have to control pain, you have to control pain. We're not doing a good job controlling pain. You have to do this, you have to do this. So we're feeling immense pressure. And they're giving us a very easy way with all this massive, heavy, aggressive marketing. Here's the answer for you. And so many of us stepped into that to try and do the right thing. And it kind of took us on a bad path. We had a bad trip. So this is from Shakespeare. There's one pain I often feel, which you will never know, and it is caused by the absence of you. We have lost so many million people to accidental, intentional, every kind of opioid-related death that you can imagine. So it is a very devastating thing for families, for communities, whole communities, because it's never just one child. It's several children. It's several people in a community that suffer because of this. So what happened was, as the opioid sales started to skyrocket, so of course did the number of deaths. The number of deaths, you can see, well, maybe you can't see, it actually got up to anywhere around about 60,000 people, right? That is more than the number of deaths for motor vehicle accidents. Okay, that peaked in about 1972 when we implemented mandatory seat belting. So we've got a problem, and it mirrors the sales. And so what they started to do, and what CDC and them are doing, is they're going after the supply side. Who's the supply side? Us. We're it. And so that was the easiest target for them to go after, right? Because it's very difficult to control things that are happening on the street, on the demand side of things, right? So the easiest target was us. So that's what they're doing, is coming after us. The issue with this is that patients are still saying, I have uncontrolled pain. You have to do something about my pain. Even though our prescribing increased 400% or more, there was no change in the number of people who reported severe disabling pain. We didn't even make a dent in it. So we have death with no benefit. And so we've got to somehow rebalance that equation. So this is actually just a picture of Iowa. The darker counties are the ones where they have seen more deaths related to overdose, either intentional or accidental. And many, many are accidental. Many are accidental. And you can see where we are now, over here in the Polk, Dallas, Story County area. Polk County is pretty high. In fact, it's 25% of all the deaths in the state happened in Polk County. You can also see, if you look at where the interstates run in our state, 80, 35, the river, where we're only a couple hours from Chicago, the DEA is working very, very hard in a lot of these metro areas to slow things down, to prevent the heroin from coming and taking over. Some success, we're still seeing deaths. The good news I have for you is Iowa never is right on the cutting edge of a trend. We're a little bit behind on fashion. We're a little bit behind on a lot of things. We also happen to be a little bit behind on jumping on the opioid wagon. We tend to sit back and say, let's see how everybody else does it, and then we'll decide whether it's a good thing for us. That's a good thing. And overall, we can see that the opioid use in morphine milligram equivalents has decreased from 2010 to 2016. Ever so slightly, but still, it's a good sign. And overdose drug deaths in Iowa have gone down. It's kind of leveled off since 2014, and we're seeing heroin do a little bit of an uptick. Okay, less prescription opioid deaths, more of an uptick in heroin, and that's what we're seeing nationally too. It's not huge in Iowa. They're expecting it to peak in about 2 or 3 years here. So the more we can help people now not go that way, the better off we are. So this happens to be from the prescription monitoring program. I hope you're all aware of it and signed up if you're prescribing. And if you're students, you can get a student sign-on as well, I think. So anyway, this is 2017 data. And what it shows is that, and this is pretty consistent the last couple of years, we're big prescribers of hydrocodone. That's the green area, or blue area down here in the corner. And up here is our tramadol. So what has happened a lot is that we've moved away from some of the OxyContins of the world and moved more into our hydrocodone. We prescribe a lot of hydrocodone, but we're prescribing more tramadol now, thinking that maybe it's a little less toxic. The other things haven't changed too much. In Iowa, we still prescribe a lot of stimulants, but that's not my talk. So what I wanted to point out, though, was the trends that show that we've been doing a really good job here, right? We're not perfect, but if you look up at the top, and you can't see these numbers, but from 2011, there were 14,000 people registered, okay, prescribers, and there are 17,000 now. So we have more controlled substance registrants now, and you can see down lower, the number of requests processed from prescribers went from 71,000 to 347,000 requests for the prescription monitoring program. Yay, we're knowledgeable. And you know what the results are? The results are, down here you can see, and it's based on C2s, and the next section is 3s, 2s, and 3s, and then 3s, 4s, and 5s, the whole mix. But you can see on C2s that in 2011, we had written 322,000, almost 323,000 prescriptions. We're now writing 679,000 prescriptions of C2s. We're writing a lot more C2s, but look what's happened here. The number of pharmacies, the number of patients that are getting prescriptions at 10 or more prescribers or 10 or more pharmacies went from 249 to 194. So we're having less doctor shopping, less pharmacy shopping. We're having single entity providers, prescribers ordering a little bit more. The question is, are we doing this in the patient's best interest? Are we giving more short-term prescriptions? That's the data that we don't quite have. Is it a 3-day supply in the ER? Is it a 7-day supply after ankle surgery? That type of thing. That's the data that we don't quite have now. We know that we're prescribing a lot, so we're addressing this. We're not afraid to use the medications, and it would seem that we're doing a very good job keeping that patient with consistent care with one prescriber. So I think that's overall not bad, but we still have to treat patients, and we're still scared of killing people. I don't know about you all, but that's what I'm scared about. I want to help them without hurting them, right? That's the oath that we take. So how do we do this? And I wanted to use, here's just the CDC guidelines. We're going to go through those. If you haven't seen them already, you're more than welcome to look them up. So another quote, the poor wretched soul, bruised with adversity, right? Bruised with adversity. We bid be quiet when we hear it cry. I don't want to hear about your adversity and your pain, right? I don't want to hear it. But were we burdened with the like weight of pain, as much or more, we should ourselves complain, right? So it's very easy to tell patients that are miserable, right, and suffering that we don't want to hear this. Here's a prescription, get out of my office, I got things to do, right? It's very easy to do that. But when we put ourselves in their position, it's a very different story. Okay, so here's JR. He's actually a patient that I saw in clinic last week. 54-year-old guy, low back pain. Tried one of his wife's Vicodin, felt better, so he comes to the office, and that's what he'd really like for his back pain. His BMI was 48, mostly here, because he lives in Iowa. So he describes this axial low back pain without any radicular symptoms, no motor weakness, no bladder and bowel problems, worse, and it gets worse with any activity. So no red flags, right? We don't need to send him to the surgeon or anything like that. He's just got mechanical low back pain for the most part. He's got diabetes, GERD, hypertension. He had a DVT at one point, major depressive disorder. He has a history of alcohol use disorder. Okay, he has insomnia. He has OSA. He's got a CPAP, and he has hepatitis C. So, not an easy guy, and I shortened his list. These are the kind of patients I see in my clinic every day. So physical exam was unremarkable, except he was tender to palpation over his lumbosacral spine area. Here's his MRI. I know you guys aren't all about MRIs. My people are all about MRIs. But what I wanted you to see was this is a very typical MRI reading for somebody with chronic mechanical back pain. Dr. Pearson, you can correct me if I'm wrong on this. But I picked this because it's very typical. Yes, he has some hypertrophic facet changes. He's got arthritis in his back. By the time you get to be 45, you probably do, or 54. You probably do. I do. You know, my neck has some, right? And a diffuse disc bulge. Okay. We don't have any symptoms that are consistent with that, any nerve root impingement. So again, we're still looking at, we got some mechanical low back pain, right? Nothing that's scary here. His medications would be his antidepressant, his metformin, lisinopril, common things that we see. But I want you to pay attention, so because we're talking about opioids today, right? Is there anything on this list that concerns you right now? Just looking at the list. Somebody said benzodiazepine. Okay, file that away. So what kind of pain does he have? This is how I start every single patient. This is how we teach our residents, our medical students, pharmacy folks. What kind of pain does the patient have? Does he have somatic pain, dull, aching, well-localized, musculoskeletal type pain? Does he have that? Does he have visceral pain, where it's very weird, the enteric nervous system is involved, we can't localize it, it's not responsive to like anti-inflammatories? And then there's the neuropathic side of things, right? It could be peripheral, like a diabetic neuropathy with nerve damage in the periphery, or it could be central, where there's nerve damage somewhere in the central nervous system, right? So pretty basic, I know, and pain is more complex than that. But when we talk about treatment, and sadly for physicians and diagnosticians in the audience, I'm going to make you shudder here. As a pharmacist, I don't care what the diagnosis is, okay? I care what their symptoms are, okay? I really, really care what is the pain generator and what kind of pain symptoms do they have, because that is how I will recommend drug therapy, okay? My docs need to know the whole diagnosis and the MRIs and all that kind of stuff, because they're going to poke somebody, right? Maybe. But all I really care about is what is the pain generator, okay? And what kind of symptoms do they have, so I can apply pharmacotherapy. So we use a multimodal approach. We use cognitive behavioral therapies. We have a psychologist. Interventional procedures, we got lots of that. Physical rehab, we work really closely with our physical medicine rehab folks, PT. And then, of course, pharmacotherapy, which is, you know, near and dear. And I just listed some examples on the right-hand side. We use all those types of things. We don't use ketamine on the outpatient side right now. I know that's kind of a hot-button topic. We just don't do it on the outpatient side for several reasons. Here's the interventions that are many times targeted to this type of patient. We do interventional things for all those things, failed back, radiculopathy. We do some facet joint disease. If they're symptomatic, if they're having radicular pain, if we're getting a lot of disability and dysfunction, we can try and address those facet joints. Here's the pharmacotherapy stuff, which, as we're talking about opioids, we can't just use opioids. So if you hear me talk at all, I think that opioids are the sprinkles on top of the cupcake. And that's how frequently we should use them. Okay, a sprinkle here, a sprinkle there, like pixie dust, right? A little bit on top of everything else that is our foundation, our cake, our frosting, and then there's the sprinkles, okay? That's how they work best. They work best with something else. So you can see if we've identified some type of musculoskeletal pain, myofascial pain, or neuropathic pain, right? So what does JR likely have? Anyone? Musculoskeletal pain. Thank you. The students are rocking. Where are my attendings? So musculoskeletal pain. He probably also has myofascial pain, right? He's tender to palpation. And most people with mechanical low back pain have myofascial pain. Universally, they have myofascial pain. So if we're looking at drug therapy, What are our choices? Well, maybe an anti-inflammatory, maybe an antidepressant for musculoskeletal pain, because they're FDA approved for that. What about acutely? We could use some muscle relaxants. For myofascial pain, occasionally we will use them only to help them get through PT. And then, of course, opioids are actually third line for any type of musculoskeletal pain. And then topicals. And that would be more related to osteoarthritis, not this guy's low back pain. A topical is not going to work for his low back, especially at his weight. There's no way that medicine is going to penetrate to anything that's going to be useful. And then you can see the neuropathic stuff, which we're not really going to address today. But take a look at these things. And when we approach the patient, we say, oh, gosh, he's got musculoskeletal pain. He's got some myofascial stuff. That's where we're going to focus our therapies, right? And opioids are way down here. I mean, they don't typically even enter my conversation with someone who's opioid naive because I'm probably never going to go there. We're going to use things that we know that are effective, have evidence-based, things that are actually going to help them get better. Are opioids effective? Right? For low back pain, they should be reserved for refractory, severely disabling pain. Long-term, they've never been shown to improve function, so we tend not to use them. Osteoarthritis, second or third line. Neuropathic pain, second or third line, and I never use them alone if I can help it. And then absolutely not for any type of central sensitization syndrome, okay? Not fibromyalgia. Nobody has diffuse widespread pain. That is a central sensitization syndrome, and we do not use opioids for that because opioids make it worse. Got data. It happens. And I could talk for 3 hours on that, so don't get me started. So back to him. So he's got, we think, musculoskeletal pain, myofascial pain, and we looked at our list of medications. What might we use, right? Might we use nonsteroidals for him? Oh, what are his disease states? Oh, he's on warfarin. Well, maybe NSAIDs wouldn't be that great, okay? Any other contraindications for his comorbidities or meds? Huh? He has GERD. That could be a problem, right? I don't have his stuff in front of me. You're going to have to tell me. He's got Hep C. Okay. Was that a problem for nonsteroidals? No. Acetaminophen. That's a problem, right? Dang. Okay, so maybe NSAIDs aren't a great choice. Maybe acetaminophen's not a great choice, but I'm documenting this in my note as I go through. These are first-line therapies. NSAIDs are going to be risky because of this. Acetaminophen is going to be risky because of this. What about gabapentin or an anticonvulsant? Yes? No? Come on, you guys. Probably not. He doesn't have neuropathic pain. He doesn't have a radicular component to his pain, so probably not. What about an SNRI, like duloxetine, venlafaxine, a tricyclic antidepressant? Yes, no? So actually, for a typical low back pain patient, duloxetine and venlafaxine are actually excellent choices as far as I'm concerned. The problem with this guy is he's got Hep C, and that's almost an absolute contraindication for using duloxetine. Could we try venlafaxine? Maybe at a low dose is a possibility, but he's on fluoxetine, right, an antidepressant, so we've got a drug interaction going on there. So that could be a little iffy unless we're working with the prescriber of the fluoxetine. We need to, careful. And a lot of times we will recommend talk with whoever's ordering your Prozac and see about how they feel about a rotation. I'm not messing with their depression meds. I don't want to be responsible for that. And what about a muscle relaxant? He's not complaining about any spasms, right? But as he gets into PT, like he should be doing, right? So PT is probably the best thing for him. But if we're going to add a medication because he gets getting spasms after his PT sessions, okay, maybe. Okay. Short-term use, PRN use is probably fine. And then that darn opioid. Is there any reason why we shouldn't give him an opioid? He has a history of substance use, right? Okay, that's a concern. Let's talk about that. So if we are considering opioids in any patient, we have to talk about the risks versus the benefits. And I talk about this flat out with patients, flat out. Okay, not only for his low back pain is it generally not effective long-term, right? We need to check the prescription monitoring program, right? Baseline, don't ever touch a controlled substance prescription pad unless you've checked the PMP. because you want to know what else has been going on, who's been involved with this person's care, and should we even attempt to go there? Because the last thing you want to do is be the 5th prescriber of the Vicodin, right? You don't want to go there. And it's okay to show that patient the report. I do it all the time. I'm like, oh, we've got this database in Iowa, and it looks like, you've been getting this from this person, and this from this person, and that concerns me. It makes me think that maybe you need a little bit more focused care, and this could be really dangerous for you, okay? It could mean death for you if you're not really careful. So we do the urine drug screens. We calculate their total. If they come to us on opioids, we calculate their total morphine milliequivalents a day. And then we document. Okay, this is what it's coming down to, guys. CMS, insurance companies, the DEA is going to want to see documentation that you have checked the PMP, that you have done your urine screens, you've done all these things before you take that step with somebody. Okay, you have to protect yourself and your patient. Okay, so how do we know if he's going to abuse them? Well, it happens, right? Across most calculations, the rates of misuse are anywhere between 20 to 30%, right? Addiction, okay, which is I can't stop myself from doing this. Misuse could be I'm taking 3 instead of 4, or 4 instead of 3, or maybe I take it a little bit differently than what's prescribed. Okay, maybe I'm using it for sleep instead of pain. That whole thing. So there could be misusing, but addiction is anywhere from 8 to 12. And I would argue that these statistics probably aren't capturing a lot of the addiction that's happening now. So it's probably higher than that. Abuse is reported in only a single study. I don't know where that came from, Dr. Pearson. There was one old study that Purdue used as marketing and said, inpatient post-surgical patients, there was a very low risk of abuse. Of course there is. There was only one study that looked at abuse. Okay. So at least in 2015. All right, so we screen. Okay, we do this in our clinic, and it's very easy. The ORT is very easy. 4 questions that you get the data for. Patient doesn't have to do anything. You just run through them with them. Basically, what's their history? There's a dyer, which is a little bit more involved. The soap is a little bit more involved, mostly used for research purposes. And then on the bottom is the community opioid misuse measure. I use this in my clinic all the time for patients who are already on opioids. And it asks them about 9 to 11 questions. Are you concerned about how you're taking the medication? Is your family concerned about how you're taking the medications? Do you get angry? Do you get emotional when you think about your medications? Do you think about your medications a lot? Those types of things. And if you get over a 9 or something, then that's a high score for they're probably at risk for misusing their medications. So doing those types of things ahead of time, again, if you can document those very simple things, because I have sent back to primary care folks, their ORT is this, okay? And either they're fairly high risk, I would really caution you if you're going to think about an opioid, or their risk is very low. I think if you feel it's appropriate, then I would go ahead and give it a try. Drug testing, at baseline, absolutely. I had a poor man in clinic yesterday who I couldn't do, usually we do observed, which I couldn't do with him. Can't do, opposite gender, but he had a catheter. He had to cath himself got to do it. And so we were there at 5 o'clock and he's, cathing himself in the bathroom so I could get a urine sample. But we try and do same gender observed collection because we've been burned. So some of the recommendations are 6 to 12 months if they're pretty low risk, every 3 to 6 months if they're at high risk. The problem is if you do it every time, some places do it, you got to give a urine sample before you get your prescription. Well, that patient knows you need a urine sample. 9 times out of 10, they're going to borrow some or rent a pill, give you exactly what you want to see, and then go back to whatever they're doing after they get their script. So you have to know how to interpret those things, and you have to talk about it with the patient. So the patient that one of my docs had yesterday or earlier this week there was a metabolite of cocaine in the urine sample. Okay, there wasn't any of the hydrocodone that we prescribed. This is a problem. Okay, so it means we're going to sit down and talk with the patient and probably not use opioids in their care. They're still going to be under our care if they choose to. We're just not going to use opioids. Too risky. Okay, so what about overdose risk, right? We're worried about death, right? We want to do the right thing, but we also don't want to hurt anybody. So how do we assess for risk? We talk to the patients about what the risks are, right? This is not a freebie. I put opioids in the same class as prednisone. Unless you're going to give somebody pretty darn high dose prednisone for the next indefinite part of their life, and that should all make everybody really nervous, right? We all know the dangers of prednisone. Opioids are very similar long-term adverse effect profile. So we have to really think about those long-term things. And I talk with patients about those long-term concerns. So it's a risk for them to be started on this. And it's kind of an informed consent. So Riosort, and again, you probably can't see this, but you can Google this and get this Riosort. This is what a lot of pharmacies in Iowa are using now. The pharmacists are doing quick assessments of what the risks are for opioid-induced respiratory depression. This is a risk index. It was first studied in the VA population and then validated outside the VA. So a lot of these testing is being done. You come to my clinic and you're on opioids, you're going to get one of these, this type of assessment, because they need to know what their risks are. Okay, so this person has substance use disorder. Okay, so he gets 25 points. He doesn't have some of the other chronic diseases that happen to be on this one. He's got lots of them. They just don't happen to be on this one. Okay, he has a prescription for a benzodiazepine. Somebody mentioned benzodiazepines. A prescription for an antidepressant. Well, he's on fluoxetine. Okay, so he's got 8, 9, 17, 25, total of, did I add that right? I don't think I added that right. What's 25 and 17? 42? 42. Oh, please. How many college degrees do you need? So 42. So if he had 42, what risk category would he be in? 7. Okay? Anything category 4 and above probably should have a naloxone prescription to go home. Right? This man hadn't even started on opioids yet. Sir, your risk of dying from opioid respiratory depression is 83% if we give you an opioid. Even if his ORT was 0, which it isn't because he has a history of substance use disorder, there are some risks here, okay? And this is what I do with patients. I'm like, hey, risks and benefits, right? And they might need to go home with naloxone, okay? We do this in our cancer population. We do this in our palliative care clinic, right? We do a Riosort, and many of our patients get sent home with naloxone, right? Because bad things can happen to anybody, okay? So if they're high doses, if they score high on the Riosort, if they just want it, in Iowa now, you can just walk into a pharmacy and buy it. I did. I have young people still in my home, okay? They go to parties. My son is in college at UNI, and guess what? They go to parties. And they're not just drinking booze, right? They're not just smoking pot. They're doing pills, okay? They're doing pills. So kid's got one, okay, a naloxone inhaler. Not that I think he's going to be a hero, but there if he needs to save somebody's life, okay? We still have to work on our Good Samaritan laws. If you have any pull with our legislature, see if you can get the Good Samaritan law passed so we don't get prosecuted for saving somebody's life. Okay, I'm going to switch gears and let Dr. Pearson lead the way.
Okay, can everyone hear me? No? That seems quiet.
Can you hear me now?
Hello? Oh, I think that worked. And hopefully the webinar people can hear too. Hi. So my part might be a little bit more boring than Dr. Kral's because we're going to get a little bit more into the nuts and bolts of everything. And again, just like Dr. Kral has been saying this whole time, use your best medical judgment. And so much of opioid therapy is tailored to the individual patient. I can't give you any recommendations on always start with hydrocodone or always start with this, never use this, because it all depends. And I think between Dr. Kral and I and most pain physicians, if there's any of you in here, we've used them all for different indications. So we'll go to Act 3, choosing an opioid. So first of all, I would just want to get get over the misconception about strong versus weak opioids. It's true that some opioids will bind to the receptor more strongly and some will bind a little bit more weakly, but it's somewhat easy to overcome that based on your dose. So from my perspective, your dose matters a whole lot more than which drug you choose. So if you're going to give someone 100 milligrams of tramadol, if you go to our classic pharmacy textbook, which is Goodman and Gilman down here, they estimate that it's about similar to 20 milligrams of oxycodone. So you think about your patient who's taking 100 milligrams of tramadol 3 times a day. Well, if you calculate that out, it's probably pretty close to 20 milligrams of oxycodone 3 times a day. And just from Goodman and Gilman again, when equianalgesic doses are used, there's really no significant difference in the amount of respiratory depression that it causes. So I would encourage you all, when you're choosing a dose which medication to choose for your patient, choose it more based on the safety profile for your patient to avoid side effects and base it on their medical problems. So hopefully all of you have seen an equianalgesic dose chart. You can Google it. 100 of them will come up. And they're all pretty similar too. Trust me, I've done this a lot in pain fellowship. But basically, you can go through and choose the medication that you're thinking of starting for a patient and convert it to morphine equivalents. Typically, when we talk about opioid medications, you'll see them in morphine equivalents. They're not going to say, 20 of oxycodone equivalents or anything. All of them are converted to morphine equivalents. So if you do have your patient on, say, 20 of oxycodone, and you want to convert it to see if you're following the CDC guidelines, that's equivalent to 30 milligrams of morphine. And if you have a patient on, say, a 25 micrograms per hour fentanyl patch, that's roughly equivalent to 50 milligrams of morphine over the course of 24 hours. Obviously, the fentanyl patch is a 3-day thing, but you kind of get the idea from there. The starred ones, tramadol and hydrocodone, are considered more of a weak opioid, and that has to do with how they bind to the receptor. But again, your dose is really what matters. And then moderate opioids, in some publications, they'll consider like hydrocodone and oxycodone more moderate, whereas like hydromorphone and fentanyl would be stronger opioids. Okay, so choosing the opioid based on your patient's comorbidity. And I think Dr. Kral did a nice job segueing into that when we were talking about our patient, JR. So patients with renal disease, there's certain opioids that will have a toxic metabolite that can be very dangerous for patients. It cause seizures, be more likely to cause respiratory depression. And typically, it's the opiate medications, the ones that actually come from the poppy plant and are not synthetic. So those are like codeine, morphine, meperidine. I don't think anybody here is prescribing meperidine as an outpatient, hopefully. And then any patient with cardiac conduction abnormalities, you have to avoid methadone because this will increase the QTC, which is the length of the QT complex. Your patients with liver disease, we kind of touched on this with our JR patient. All opioids are metabolized in the liver to some degree. And be very cognizant of opioid formulations that also include acetaminophen as well too, because you can very easily give them too much. With elderly patients, this is one that I kind of struggle with as well. Many of them cannot handle NSAID medications. A lot of our other gabapentinoid type medications can cause mental fogginess. They get sleepy. We struggle with that. But at the same time, when we go head to head and compare, say, NSAIDs with opioids for the elderly, they have a higher mortality, more cardiac disease, higher risk of fractures, presumably from falls, and then higher risk of bowel obstruction too. So these are just things to keep in mind for your patients. Hopefully many of you guys have already heard of CYP2D6. When I said previously that all opioids are metabolized in the liver, this is one of the major enzymes that metabolizes opioid medications. It's totally ineffective in 10% of Caucasians. So for some opioids, they have some effect, and the liver will convert it to another opioid, which also has an effect. So if you have a patient who says, yeah, I take this medication, it's not that effective for me, they may be one of these people where they cannot convert it into an also useful substrate. The problem that we have with codeine is that codeine is a 100% prodrug. It does absolutely nothing unless it is converted by CYP2D6 into morphine. So 10% of patients, codeine will do nothing for. The other problem with codeine is that in certain patients, the opposite happens. They're way too effective with CYP2D6, and they're ultra-rapid metabolizers. And if you look up post-tonsillectomy literature for kids, there have been many deaths associated with codeine, and it has been linked with CYP2D6 polymorphisms that cause them to be ultra-rapid metabolizers. And many hospitals, including the one that I trained at, have removed codeine from the formulary because of this. Other things that CYP2D6 does is convert hydrocodone to hydromorphone, which is dilaudid, and then oxycodone moves to oxymorphone. But again, hydrocodone and oxycodone, those medications have intrinsic opioid effect in themselves, but their metabolite also has some opioid effect. Okay, so common side effects. Nearly all of these side effects, your patient will develop some tolerance to. So keep that in mind when a patient's starting a medication. And it's always good to start low and go slow, which you know. The thing is meiosis, which is the tiny pupil look. People don't usually get very much of a tolerance to. So we use that to our benefit in anesthesia. I'm an anesthesiologist too, so when we're trying to see how narcotized our patients are, we always look in their eyes. And I'm sure, is anyone from emergency department here? No? But they're usually pretty good at kind of sniffing out people's small pupils. And then constipation too. There's very minimal tolerance to constipation. So as long as they're on the opioid, they will probably have some constipation issues. You have to address that. Other things, again, the opiate medications will cause some histamine release, morphine especially. And then the classic ones you've all heard of, nausea, vomiting, itching, urinary retention. All opioids cause some kind of biliary spasm. It's just that morphine seems to cause a little bit more of that. And then, as Dr. Kral mentioned, opioid-induced hypersensitivity. For some reason, people who are centrally sensitized to pain tend to be a little bit more sensitized by opioids, and we don't really know why. Endocrine and immune effects. This is just one very busy slide just to make sure that you guys know your patients on long-term chronic opioid therapy will probably have decreased testosterone. It is worth checking if you have a concern. Women may notice menstrual irregularities. Both men and women can get osteoporosis or thinning of the bones. And it can dysregulate the HPA axis, the hypothalamic pituitary adrenal axis as well. So that allegory to prednisone is not all that far off when we look at the endocrine effects. And much newer research is finding that opioids do have both stimulating and depressing immune system effects. We're still trying to sort that out, but especially in cancer research, there's thought of, do we need to look into that? Can opioids help us modulate, or do we need to avoid opioids for some cancers because they actually will make them grow more? So I can't talk more on that because we really don't know a whole lot more yet. So just to get into just a few specific medications, hydrocodone prescribing, were any of you guys around in 2014 and kind of remember that? Anyone out there? When they switched hydrocodone from Schedule 3 to Schedule 2? Any of you guys? No? Oh, pretty new? Okay. So basically, Schedule 3 is a lot more open. Schedule 2 is a lot more strict. So basically, for prescribing hydrocodone, refills were limited. You required a hard copy. Patients required follow-up. Whereas other things like codeine and tramadol, you can do oral or electronic prescribing. You can do refills. They're a lot easier to do. So when hydrocodone was rescheduled, of course, people cut back on their hydrocodone prescribing because it's a lot more difficult. Then they started prescribing a lot more codeine and tramadol. And like we talked about with CYP2D6 polymorphisms, maybe that wasn't the best switch, but we did cut down on hydrocodone prescribing. The other misconception I just want to clear up is that tramadol is an opioid. It just doesn't bind to the mu receptor as strongly as other opioids. So it's on that continuum. It also has this funny SNRI effect too. So it works a lot like your SSRIs, any other antidepressant medication that you would give a patient. David Gerlich is a pretty famous toxicologist and physician in Canada. He likens it to giving venlafaxine and morphine in an unknown ratio. Because again, tramadol, of course, is metabolized by this 2D6 polymorphism. So it's kind of a difficult drug to manage. And Dr. Kral knows me well. I tend to prescribe a lot of duloxetine for my patients. So if you have a patient also on tramadol, you have to worry about all those serotonin side effects. You may be giving them a little too much. And you'll notice your tramadol patients, it's hard to get them off of that because they're also getting that SNRI benefit. And then tapentadol, you've probably heard of, that's very similar to tramadol. Fentanyl, probably not a whole lot of you are prescribing it on a daily basis in the outpatient clinics, but it's a great drug for anesthesia and acute pain for palliative medicine, but for your chronic low back pain, standard chronic pain patient, probably not the greatest first-line effect. CDC is pretty clear, don't use transdermal fentanyl for your opioid-naive patients. And abuse can be very fatal. There's reports of babies kind of picking up those fentanyl patches. They're clear and thin. You can hardly see them. If they're on the carpet, they put it in their mouth. It can be very, very dangerous. Obviously, I'm from Minnesota, so I have to put a picture of Prince up. Many very famous musicians have died because of the effects of effects of fentanyl. Methadone, hopefully not many of you are prescribing methadone for chronic pain. It is a great drug because it's very well tolerated in renal disease. And for those patients who have that opioid-induced hypersensitivity, it may be a better choice than others. Lower addiction risk with caveats. It's very cheap, and it lasts quite a long time. The problem is with liver disease, extensive hepatic metabolism, your patients need frequent QTC monitoring with EKGs. And typically, this is per the ACIP guidelines, which is my specialty society. They should be probably prescribed by someone with special training and close follow-up. So what opioid would you choose for JR? And I will say up front, there's probably no great perfect answer. But is there anything that you wouldn't do? Gives you pause. Someone say E. Okay. Thank you, Dr. Kral. So yeah, I would avoid fentanyl patch. I would avoid C because of the acetaminophen. Methadone, again, this is not one to just willy-nilly start on an opioid-naive patient. Tramadol, there's concern with the liver disease and the 2D6 metabolism. He's already on an SSRI. So good old garden variety morphine may be his best choice. Okay, now prescribing these. This is just a few slides. Can you prescribe opioids? This is tongue-in-cheek, but yes, you can prescribe opioids if you have an active license in your state, you comply with all state and federal laws, and I don't know specifically nurse practitioners, physicians, you have to look it up yourself. And you cannot prescribe opioid medications or any other controlled substances for yourself and your family. But as long as you do that, you may prescribe opioids. But what dose do you start with? This is the CDC guidelines. So CDC guidelines will say low dose is considered 50 morphine milligram equivalents or less, okay? The ACIP guidelines say 40, so that's why I put that in there. Moderate, 51 to 90, ACIP will say 41. And then high, greater than 91 MME. And again, if you're thinking about one of your particular patients, make sure that you adjust it to the morphine equivalent of it. So if your patient's on, 20 of oxycodone, they're actually on 30 morphine equivalents. So definitely calculate this for your patients just to see if you're on a decent track. Whenever you're starting them, always start low. Always use the short acting. It's easier to titrate and take it slow. So how do you start this with a patient? Educate them. We say a goal of generally more than 30% of an improvement in pain. The reason being, if you look at any study of opioid medications, the placebo effect itself is 30%. So your patient needs to at least show you that it has more than a placebo effect. Does that make sense? Hopefully. And for me as a pain physician, I care a whole lot more if this medication helps them function, okay? You have to communicate your risk and what your criteria are for discontinuation so the patient knows upfront what you're thinking. I tell my patients don't drive until there's a stable dose of opioid reach, so that can be very motivating for them to work with you and find a good medication dose, and then avoid all other sedating drugs, including alcohol. And generally, I think our patients are pretty good. We're very clear about that up front. The ACIP guidelines will say titrate over 8 to 12 weeks. So up front, you're telling your patient, we're going to prescribe this medication. I want you to come back in a week or a month or something. We'll take a look. Has this improved your function? Has it improved your pain? If so, fine. We stay at that dose. We're good. If not, we make an adjustment. Come back. Let's see how you're doing. Patient knows ahead of time, okay, we hit the 8 to 12 week mark. We still haven't found a stable dose. Then either you need to taper because the medication's not working or it's not fulfilling the goal that you wanted, or you consider referral to a specialist. You can always consider referral sooner. So question, what kind of dose would you want to trial for JR? Long acting, slow, short acting? A lot, a little? Yeah, see. So IR means immediate release, so you'd want to use a shorter acting medication, and just start with 60 tabs. Go from there, see how he does. It's supposed to be PRN, okay? Okay, we like to use this. You can build this into your EPIC notes too, pretty easy. 5 A's, analgesia. Did it improve your pain score by at least 3 points? Have you achieved your activity goal? I like to put this in the patient's note before we even start the opioid medications. What's your goal? You want to get out and have coffee with your buddies? Okay, I'm going to ask you about that in a month. Aberrant behavior, you have to address it directly, okay? And up front before you even start, if you're concerned. Adverse effects, and then their affect or mood. Okay, I think this is probably one of the most important slides, and I apologize if it's a little bit of editorializing, but I really do think that how you speak is how you think. And patients are very sensitive to how you talk to them. And I think they don't want to be labeled as an addict because they think that they'll get abandoned. So really think about how you use words around opioid therapy. It's very easy to use opioids and pain medicines interchangeably. So if patient's in the ER and you know you're not going to send them home with the opioids that they want for a headache, don't say, I'm not going to give you any pain medicine. Of course you're going to give them pain medicine. You're going to suggest Tylenol. You might start them on sumatriptan. Those are medications for pain. So broaden your idea of what pain medicine is, at least for your patient's sake, and help correct them too. Painkiller, this is in the media all the time, but we know that no drug kills pain. Whenever we start medications, we're always saying this will help ease the pain, at least that's our goal, but it's not going to likely cure it. For some people it does, but it's very unlikely. And usually side effects get in the way anyways. Don't use phrases like cut you off. It makes you sound like you're the dealer and not the prescriber. And then the difference between opiate, opioid, and narcotic. So I'm a pain researcher. I get a little picky about this. Like I said earlier, opiate is medications that actually come from the poppy plant. This includes heroin, codeine, morphine, but it doesn't include all the synthetics like oxycodone or fentanyl. Opioid includes all of those things, synthetic or naturally occurring. Narcotic is more of a DEA kind of terminology. So narcotic will include anything that has kind of an effect on the sensorium and is typically abused. So it could be a benzodiazepine, it could be cocaine. That's all in the narcotics division. So I'm picky about verbiage, so hopefully you will be too now. And please don't label your patients seekers or addicts. People who are addicted to opioids still also need your love and attention. So labeling is not therapeutic for them. Okay. And a prerequisite to empathy is simply paying attention to the person in pain, which sometimes can be hard. Okay, tapering. This is a pretty quick one. Is it okay to stop opioids? Yes. And your patient already knows that you're thinking about that, and that may be a possibility. It's also okay to continue opioids, and the patient already knows your criteria for continuing the opioids. You're all on the same same level there. However, tapering opioids, especially high-dose opioids in a controlled setting, it has shown to reduce pain and improve the mood for those on high doses. Also, there's an association between prescribing and increased disability, medical costs, and subsequent surgery. It's just almost impossible to extricate those things. Is it more having to do with the prescriber, more having to do with the patient, or the situation, or the medication itself? Very hard to figure out. Why is it hard? Tell your patient up front, I expect that you will develop a tolerance to this medication. We just have to decide where we're actually going to stop. When withdrawal symptoms can occur with very short doses, in the anesthesia literature, you can give a dose of medication to someone who doesn't have pain, give them naloxone, they will develop withdrawal symptoms within hours of having that opioid. So pain is a withdrawal symptom. So even people who don't have pain in a research type of environment, they're given an opioid and then taken that opioid has been taken away by naloxone, they will develop pain as a part of the whole withdrawal syndrome. So when your patient's really concerned about weaning down on opioids, they probably will have more pain regardless of the pain that they started with. It's just a part of the withdrawal syndrome. We talked about opioid-induced hypersensitivity, so you have that extra layer of generalized pain on top of the pain that they started with. And then it can be influenced by their mood and substance abuse history, as you can imagine. So how do you stop them? Again, they know your criteria. If the patient's only been on it short-term after surgery or something like that, you can just simply discontinue those. Typically for me, I'm chronic pain, so I tend to see people on it for a long time. I go down by 10% per week. I'm not trying to be a hero. I'm not trying to it's not a race. I want them to have the best experience coming down on these, so we just take it very, very slow. If you do need to taper somebody faster for different reasons, or if they're having withdrawal symptoms, clonidine is an okay medication to use. You need to understand that medication, be comfortable with it. But typically I'll use that. And in the addiction literature, at least, withdrawal symptoms can persist up to 6 months. So definitely follow up with your patient. If they're having insomnia, mood issues, all those other things, don't abandon them once you've tapered them off of medications. Make sure you're using other modalities. And then if there's a concern, addiction medicine referral. So the great art of life is sensation, to feel that we exist even in pain. I think we've all experienced pain ourselves, and hopefully we can use that as a part of empathy. So the summary, I think we've hopefully beat that over your head, but the guidelines are only to inform your clinical judgment. If your patient's on high dose and that's what you need, you've documented it, you've tried a taper, it didn't work, it's okay. Just keep documenting. Try the non-opiate options first, start low and go slow, address the risks, continue monitoring, and it's okay to taper or continue opioids as per your indications. And these are great readings here, especially this one, opioids for low back pain. It really lays out a nice coverage of very many topics related to opioids for low back pain. So I know that was a lot of information in a short amount of time, but I think Dr. Kral and I are very happy to answer questions for you. Any questions? Anyone?
Not a question, just a comment. I'm glad that it was mentioned about the Good Samaritan. The region institutions last year, the 3 presidents of the student bodies of the region institutions went before the legislature, and I think what they referred to it was the medical assistant amnesty bill. And it didn't get a lot of traction, but they're circling back, and I know at least the president of our institution here at Iowa State went back to the legislature last week, and in the culture and environment in universities today, a lot of organizations and students, but especially organizations, are reluctant to help people because of sanctions by the institution to judicial affairs. But I think this medical assistance amnesty bill has a lot of traction right now. And I know the student organizations I'm involved with, talk to the students commonly about this. So if you know any legislators, I think it's really important that they get this bill through this session.
Thank you. I think it's especially important to the college students because they know somebody, or they know someone who knows somebody. I mean, more people have died in 1 year from opioid overdose than died in the entire Vietnam War. You know somebody who knows somebody who's died from opioid prescribing, or not from opioid prescribing, opioid overdose.
Thank you.
Yeah, thank you.